Thank you. Thank you so much for that lovely introduction and for inviting me to speak. And yes, absolutely, I have brought a few friends with me because that's kind of the way I end up doing things. And I was asked to talk about the lithotomy challenge, which I've come on to. But the whole thing is trying to make you understand and realise that little things that cost no money, that you can integrate into your practice, make a big difference to the women we care for. Next slide, please. So why am I here? Well, Sue mentioned I've been doing 10 years. It seems incredible that a decade's passed. So I was on the London Maternity Clinical Network, and at that point I had what was called the patient experience subgroup, because we were talking about patients, and that evolved over the time I was there to become the Strategic Maternity Voice Partnership for London, with a co-chair, a lay co-chair. So you can see how things have developed over the years. But what we decided was we were going to run some workshops, these Who Shoes workshops, which are centred around a board game using lived experience. We were going to have a very small pilot in maybe one trust or just one sector, and then see what happened. And as Sue mentioned, the whole thing kind of blew up, and we had people online, on Twitter, on Facebook, and workshops up and down the country, and everyone trying to improve maternity experience. Now, one of the outcomes of that initial set of pilots, which we did at 5 hospitals in London, was to draw together some of that lived experience into a little film. And I thought I would show that film today as a little bit of a kind of scene setter. Next slide, please.
Hello.
Hi, miss. You're needed for a major obstetric hemorrhage. Labour ward, room 32.
It's sort of cool that really gets your heart racing is they ring you and tell you there's a major obstetric hemorrhage, and you haven't got any more information than that before you set off for the hospital.
Thursday night was a pretty tough time, actually. When your partner's in that pain, it was how can you be useful?
I was asked a few things repeatedly by the midwives because it was a new person, it was just like starting from scratch. There wasn't a sense of one-to-one care or anything like that.
Emily was asking, should I be worried about any of this? And the midwife said, if there's only myself in the room, then you've got absolutely nothing to worry about. If there are more people in the room, then there is something wrong. They are all trained, they're there to do a role, and they will fix whatever it is that's going wrong. At the end, we had 10, 11 people in the room, and I was in the corner holding my brand new baby child.
When my son was being born, his heart rate started to drop. So they sounded the alarm. The room filled up with people, but I had my eyes shut, and my husband just said to me, it's okay. And he had one hand, and then I had somebody else hold my other hand. And I don't know who that person was, but it was like they were there just to reassure me.
I was being monitored behind the curtain. I could hear midwives complaining about being tired. This made me feel like I was an inconvenience.
I've looked after a lady in labour who was hard of hearing, and she communicated by lip reading. I had to remember to keep looking up and using my thumbs and saying, yeah, the baby's coming. And like just facial expressions. And when she delivered the baby, I just looked up at her, and she was like crying, her partner was crying, and then I started crying. It was just lovely.
After my son was born, they transfer you to the postnatal ward. Everybody who saw me said, congratulations, well done. And it made me feel like a queen, because it was kind of, I'd done the best thing that my body could do.
I was encouraged to breastfeed, and for me, I did find it quite challenging. I was told a lot of different things, and I just wish the advice I'd been given by the midwives had been consistent.
I've done antenatal, I've done labour ward for years, and I've done the community, and just the whole lot of it. I love the job.
So I wanted to show that because some of the themes and things are the same, things that we should be thinking about today. The heart on the slide is made of comments from women on the MatX Facebook group about what they thought the key things were, the sort of essential words that would describe the right, good, positive maternity experience. And you can see in there, you know, dignity, choice, respect, kindness, all the things that we would hope that we would be giving every day. Next slide, please. So why am I still talking about this 10 years on? Well, sadly, it's still more than ever a problem. So Sue mentioned the pandemic. That was extremely challenging. And I'm sure that you, like me at Kingston, are experiencing incredible pressures in terms of midwifery staffing, let alone the maternity scandals and reports that are being sent our way constantly. There's also been this issue with lack of equality or equity across services for women that perhaps we're not listening to, respecting and responding to. And I've picked out Invisible, which is a fantastic report to go and browse through about Muslim women's experience of maternity care in the UK, and 5 times more, who did a full Black maternity experience survey, which is absolutely excellent. When I was doing my work in London, I was really shocked when I asked them to give me the CQC maternity stats by ethnicity, and they told me they couldn't because the response numbers were so low from ethnic minorities. And I was thinking, but this is London. I mean, we have a massively complex and diverse demographic. How can that be the case? Attitudes and listening to women come up again and again in national reports. Next slide, please. So what I wanted to aim to do is just share some very simple ideas and ways that you might employ in your day-to-day work. What would this be like if it was your sister, if it was you, if it was your family? Next slide, please. So I want to focus on teamwork and relationships. We all know that actually the best care for women is when we have everybody around the woman, that woman-centred care. So are we working effectively as a team? And I'm going to give you a little bit of my ideas and perspectives as an obstetrician. Next slide, please. Working with your obstetricians is really important. So we all know that continuity of care, relationship-based care is the best for women, provided by midwives. But some women need obstetric or anaesthetic input. And I've thought about this quite a lot. And I went back to the idea of, well, I'm a consultant obstetrician. What does consultant actually mean? And consulting doesn't mean that I have to see absolutely everybody. It means that I can give information or advice. So what I have done with the teams I work with, and pictured here is the perinatal mental health team, is to be a link consultant, make it clear that the midwives can email me if they're not sure, does this woman need a consultant appointment or not? What do I think? What is the benefit? Or is there a simple query that I can just answer, either with a phone conversation with the woman or an email to the midwife, or a prescription I can do remotely that might save the woman coming up to an antenatal clinic appointment, and the disruption that that's going to cause perhaps to her work or getting childcare, or at my hospital, parking. So building a relationship with your obstetricians antenatally is really crucial. Next slide, please. So then you need to use that relationship to support the woman's choices. It's not always clear what I'm expected to do. If a woman is so-called sent to me, that woman may feel, oh, now I'm in inverted commas high risk. I've got to see the consultant. That's a big scary thing. What language are you using? Are you explaining to the consultant what you're hoping, what question you want them to answer, or what the concern is that you have about this woman's care? And how are you explaining to the woman what the consultant can do? I know particularly my home birth team are very much, it's okay, I'm sending you to the consultant, but it's Florence, she's not scary, we work with her a lot, she'll think about you holistically. So if you build that relationship, then you can have that to and fro, and I can email the midwives back saying, I've seen this lady, this is what I think, I don't need to see her again, you can now action what I think needs to be done, or actually I am going to see her again at 34 weeks, but these are the things I think I'd like you to do in the meantime. And think about what the impact is, because as obstetricians, we're very good when you send us people of then clutching onto them and keeping hold of them and then doing this and that and the other just in case. And then that may end up impacting that woman's choice of place of birth. Suddenly she's become an obstetric case, and then maybe birth centre or home birth goes out the window. So think about, if I send her, what impact is that going to have on her other choices? And perhaps see if you can come and sit in your obstetric clinic and see what it's like, and build that relationship with your key obstetrician. Next slide, please. And also think about your relationship with women antenatally. There's quite a shift going on. So we used to keep all the knowledge to ourselves, and we were the experts and we told people what to do, a very sort of paternalistic, old-fashioned branch of medicine. Whereas we're really trying to work on informed consent. We need to appreciate that Dr. Google is there. Every woman, as soon as you find anything, will go and look it up on Google. Women always come to me. My scan said I had polyhydramnios. I Googled it. I'm now worried. So let's acknowledge that actually the internet is there, and let's try and signpost women to good quality stuff on the internet, whether that's YouTube videos, Instagram, podcasts, baby apps. We've got Best Beginnings and all sorts of other apps. So try and make sure that the information that women are accessing is the right quality, and share that information with them so they can go away and think about their choices and think about and understand what's happening to them, and then come back at the next appointment and have a good conversation, having had a bit of time to absorb what you're telling them. Next slide, please. This is me on the labour ward. I am literally running around dealing with everything, everybody, junior doctors, junior midwives. I'm dealing with theatre. I'm dealing with more than one woman at a time. So you need to help me get grounded and focus on the woman you're caring for when I'm called into that room. Next slide, please. As a midwife, you are that key person for that woman. I try and use a woman's name on the ward round. It helps cement them in my mind as a person, not room 26 or the lady with the breech or the lady with polyhydramnios. It's her name. So we will have a presentation of what's going on in the room. And then before I go in the room, I will say to the midwife, tell me her name again. And then I'll go in and go, hello, I don't know, Sue. Hello, Sue. My name's Florence. I'm the consultant here today. And then we're starting to build that relationship. When you hand over to the MDT, telling us what's really important, this woman may have planned a home birth and she's now on the labour ward. What are the key elements of her birth preferences that could be kept? What are the key things that will help her feel safe and secure and that her wishes are respected? And can you help explain why the doctor's coming into the room and what they might be thinking about? I've had women postnatally say to me, I had no idea that when I'd been pushing for an hour, a whole load of actions were about to happen and that the doctor was going to come in and expedite delivery. It was completely out of the blue. And better still, what role can you play in making that birth environment positive and trying to avoid the need for us to come in the room at all? Next slide, please. With assisted vaginal birth, we need you. You've built that relationship with her to help explain what we're doing. Give us a good S-bar handover because we may be coming in and quickly having to get on with things. And then help us, particularly if she's got an epidural or spinal, by palpating contractions and supporting her and helping her through the birth of her baby. Sometimes I see midwives or student midwives get very task focused. You've got a lot of documentation to do. You've got to get the resuscitator ready. You've got to care for the woman. You've got to top up the epidural. You might have to give tranexamic acid. But actually what I need you to do is hold her attention and make her feel safe and supported while I'm talking to her about assisted vaginal birth. I know it's really challenging with staffing levels at the moment, but if you can have someone else there who can scribe or document, whether that's a student or whoever, just to help make sure that you stay with that woman. Next slide, please. So what is lithotomy challenge and why did I do it? Well, I had 2 emergency cesarean births. And when I'd started this work on on maternity experience, I thought about what I hadn't experienced. And I thought for NHS Change Day, I would sit in lithotomy. I thought I'd do it for about an hour. That might be enough time for the pushing phase and maybe suturing and see what it felt like. And I can't tell you how much it surprised me, because even though I saw it every day and I kind of knew what I thought it would feel like, it actually felt very different. For a start, I couldn't get into the position myself. You need someone else to do it for you. It's actually impossible. And then you feel incredibly vulnerable. People talk across you. It's incredibly undignified, uncomfortable. And actually my legs felt really quite cold on the stirrups. And I can tell you, the thing that made the biggest difference to me was actually the then chair of our MVP, who's now midwife herself, the lovely Kate Greenstock, come in and literally come up to me and she said, Florence, I was planning to come in and ask you difficult questions and make you feel uncomfortable. But when I came in, I saw how you looked. And she came up to me and said, would you like a foot massage? And I was like, absolutely yes, because everybody else was just kind of treating me like an object and she treated me like a person. So I learned an incredible amount and I've written a blog about it in the past, which I've sent the link for. But also more recently this week, I wrote a blog to go with this. So what happened as a result was lots of different people up and down the country started to follow suit and also think about lithotomy challenge. And what I wanted to do was invite a couple of them, so Deepa and Helen, to explain a bit about what they've done as a result, because I think it's something that a lot of us could think about doing. Because when you look at the CQC maternity survey, there are still women up and down the country giving birth in lithotomy, even when it's an unassisted vaginal birth, around 25%. So that's not great. We need to do something about it. Next slide, please. So Deepa, I'd love you to tell people a little bit about your upright birth project. And apologies, I didn't see your slide in time, so I made this one for you.
No, that's lovely. Thanks, Flo. So I did a QI project called Get It Right Upright. And the idea for the project was when, and I was not a midwife then, but I was an infant feeding lead, but I used to go on delivery suite, and I've seen that most women were giving birth either lithotomy or mostly, semi-recumbent. So I did a baseline audit to understand what the actual, numbers were. And to my surprise, like more than 30% of women giving birth in lithotomy and about 40% in, semi-recumbent, and, very, very limited percentage of women who were able to have their own upright position, like on a force or sideline and things like that. So the MVP was involved, and the hospital, also the head of midwifery, sponsored the project, saying that we need to change that. So we had a number of change ideas, like we first wanted to understand why this was happening. And women themselves were not aware, because the layout of the room with the bed in the center, and it was sort of, they just expected to be on the bed. Midwives themselves were like, some wanted to support it, but they didn't have the right equipment. Or it could also mean like physical challenges for midwives. The medical team said, one registrar was really honest with me. She said, if you left me alone in a room with a woman on her force, I wouldn't know how to facilitate that birth. So it was really, because it wasn't part of her training, she hadn't seen anything like that. So while we were discovering all of these things, I wanted something that would help maternity staff to feel inspired by it. I didn't want it to become another tedious thing that they had to do, because we're all busy anyway, and this was another additional thing. But I wanted something inspirational. That's when I stumbled upon your blog, and I saw you, in that lithotomy challenge, and I thought, oh my God, this is such a brilliant way, because people, when we had a doctor do it actually, and a male obstetrician, and they actually wrote down what they felt. So they felt really exposed, they felt stressed. And in fact, they were wearing clothes. We just had a hospital gown on them. But imagine a woman who is, just wearing the gown and totally exposed. And there were so many people in the room. We tried to enact a scenario. And it sort of dawned on them that, wow, how does it feel from the woman's perspective? And they felt exhausted, tired, confused. So then after feeling this kind of feelings, they decided to think about it and see how they can change it and what actions they can put forward in reducing the usage of lithotomy for things that we don't really need. Something like getting the woman ready for the doctor was also about putting her in lithotomy and waiting for the doctor to come in, and that was totally unnecessary. So we discovered a few things like that. And the lithotomy challenge was something fun to do as well. Obviously it's not fun for the woman, but as a clinician to get into that role, it was something totally different that caught everyone's attention. So that's where we started, Flo, with the lithotomy challenge.
Thank you so much, Deepa. Next slide, please. So now I'd like to bring in Helen, because Helen is doing something interesting with lithotomy challenge at Kingston again. She's thought of a way of incorporating it into kind of normal day-to-day. So Helen, would you like to tell us a bit about that?
Oh, thank you, Flo. I remember very vividly having a conversation with Flo back in 2022. Actually, I'd read something, I think, about that week about the lithotomy challenge, and I think Flo might have overheard me in our handover room, and it inspired a very big conversation about it. Obviously, within my job role, I'm embedded within practice development, so I do training throughout the whole of maternity, but I oversee the Preceptorship programme. Now, within the ACORN programme, the start of their induction is they have a full skills and drills induction week. And we'd actually just had our first cohort start. And at the end of the week, they have a suturing workshop where they're just taught everything about suturing and how we do things. And it actually dawned on me that actually I had quite a captive audience, and where I could actually embed this. And actually it seemed quite easy at the time, and a bit of a light bulb moment, and actually just integrate it. So essentially what we do is we have our suturing training, and then after that I make everybody come over to our labour ward, and then essentially we then have a hands-on view of what lithotomy is like. And what is very interesting is that even just by asking our staff members to take part in the lithotomy challenge, the vulnerability and the worriedness before they've even got to actually doing it, and having somebody like myself saying to them, you know, it's fine, is to try and get the perspective of the patient, and the majority of them are obviously willing. And it's not just about putting them into lithotomy. What we actually do is we take it in turns, and everybody's placed into the lithotomy, and we open up our suturing pack, and essentially the rest of everybody in the room continues as if we're suturing. And I obviously try and make things a little bit difficult. I start having just generalised conversation about dog walking and what the weather's like and all of those sorts of things. And then sitting and actually then pretending to suture the patient, kind of talking to them a little bit and trying to sort of emulate what we're doing when we're suturing, maybe slightly towards what we shouldn't be doing, to try and give them an overview of what might be happening. And once everybody's actually done that and taken part in it, we then have a little bit of a debrief. And I like to know exactly kind of how they're feeling. And a lot of them say, you know, that they're feeling very naked, they're exposed, vulnerable, that they're alone. There's a lot of noise, there's a lot of lights. And one of the biggest things that has come out as well is that they can't really see you. So when they're there and they're draped and you're sat down and you're kind of talking to them, they might be able to hear you. You're just a voice in the background. They can't actually see you. Then they may have somebody else and they're a student who's kind of talking to you, maybe handing you some of the equipment. And again, they may be sort of talking to the woman, but again, is it that directness with the woman? So what it does is it kind of gives them that actual view. You know, some people are obviously have had babies themselves, so they have actually been in lithotomy, so they understand what it feels like. But essentially, it's just trying to emulate what it feels like to be in the lithotomy challenge. Like I said, I've got a captive audience of my newly qualified midwives. So what I'm trying to do is I'm trying to teach from the ground upwards, so that when they're in the rooms, that they can then bring this practice model and making sure that the patients feel nice and safe and as less vulnerable as possible, making sure they're covered, making sure they're being spoken to. But moving forward, myself and the perineal midwives, we've got some study days coming up. So we're actually going to start embedding this in those as well, so that actually we can then put this to the wider part of our maternity unit, so that hopefully we can actually create a kinder environment for our patients when they have to go through what is ultimately a vulnerable time for them.
Thank you so much, Helen. I really appreciate you coming on, because I just love the idea that it's getting integrated into, this is the way we do things around here, rather than it being a special, oh my goodness. And I completely agree with you. When you ask people to do it, everyone kind of shuffles around and is really embarrassed and doesn't want to, which tells you everything about why we shouldn't be doing it for women either.
Absolutely, especially when they're closed. They have, you know, they don't have all of those vulnerability aspects that the women actually do. So
yeah, thank you. Next slide, please. So I just want to talk briefly also about theatre. So the same with theatre applies as with an assisted vaginal birth. So if you're going to theatre maybe for a caesarean or a manual removal of placenta or third degree tear repair, again, staying with that woman, suddenly she's coming into a completely different clinical environment, lots and lots of people around her, like we saw in the film. And how can you keep some elements of her birth plan on what's important to her? Next slide, please. So another ripple from the lithotomy challenge was with Catherine Maybe at Derby, who unfortunately can't join us today. but she took a different perspective and did a theatre challenge. I'm hoping this video is going to work.
We're doing it loose this time. Ready? 1, 2, 3. I think we've got to fall.
Right away.
Relax, girls. Just want to touch you a little bit. Okay.
So they did a whole theatre challenge. I love that film because we don't think about what the woman sees when we wheel her from her room through the corridors and into theatre, or even out of theatre to recovery, or from recovery to the postnatal ward. And that really brings it home to you how different the woman's perspective is from what we see. And they made a second film, which was some reflections of their thoughts of lying on the theatre table, which you can explore at Fab NHS website, which I've sent Sue some links for. But for me, one of the key things was someone saying how vulnerable they felt with their glasses off, which would be completely how I would feel. So little things like that we don't even consider are really big, important things for women. Next slide, please. So I'm hoping that this talk has given you some ideas, not only about the small things that you might do, but how you might actually go about doing some of them in your unit. And like Sue said, I'd love you to share this with colleagues, because getting a group of you together and just trying out some of these things, either on a shift if you have a quiet moment, or incorporating it into your training days, is great. Like I said, we're coming up to 10 years of MatX, and really it's for everybody, anyone that wants to improve maternity experience. Next slide, please. So think, what simple things or ideas could you take away from this hour? Could you run a lithotomy challenge or theatre challenge at your maternity unit? And if you go on the Fab NHS website, there's a specific MatX page, and there's lots and lots of different case studies and experiences from people, ideas about what things they've done in their unit, such as some of the ideas we've discussed today, but also other things like stop and celebrate, congratulating a woman when she's had a baby on her way off to postnatal, a bit like you saw in the film, or a graffiti board where people can write comments or announce the birth of their baby. All sorts of little things that make a big difference. Next slide, please. So I'm hoping that this has inspired you. And I'd love to hear your thoughts if you've got questions and things that you've been putting in the comments or sending to Sue. But that's sort of everything I wanted to bring to you today. So I hope you've enjoyed it, and I'd love to know if I've sparked any thoughts and ideas.